panel. We shall now go on to our first speaker, and who's none other than Dr. Padmaja Kumari, who's the network head, the teleophthalmology, and also senior consultant vitreoretinal services at LV Prasad Institute, Hyderabad. And she is going to tell us on something so important, NFAS OCT, does it add value? So on to you, Dr. Padmaja.
Okay. Good evening, everyone. Are my slides visible?
Yeah.
Okay. So at the outset, I would like to thank Dr. Chitra and ARC and AIOS team for giving this wonderful opportunity and for conceiving a very important topic. So NFAS OCT, does it add value? This is my topic. So what is NFAS OCT? It combines OCT with transverse confocal analysis. So it gives us a transverse retinal and choroidal images at a specified depth. So what is its advantage is that it gives you microstructural and morphological changes seen in a coronal view. And it can be layer-wise, the extent of pathology can be mapped and precise measurements can be done. And most important, it provides a view similar to fundus photography. So when I was collecting all the images for this topic, I realized that this is something like a life that is given to optical biopsy. It is a life that is given to optical biopsy of histological section of retinal layers that are seen on a conventional OCT scan. So here you can see an example of Ritesh et al. They presented the case report of a tigrade pattern on hypotonic maculopathy. You can see beautifully an NFAS image, the choroidal folds that can be seen very clearly, and one can understand immediately the pathogenesis and as well as the layer involvement. Another prominent finding that you actually look for NFAS OCT is we'll look at some case scenario. One important thing is a dissociated optic nerve fiber layer, Donfel. So on NFAS OCT, it will be seen as a concentric macular dark spots, which will help us to know quantitative evaluation of this Donfel. So Steele et al. Actually compared the type of ILM peeling with the diamond rust scratcher versus regular forceps, ILM forceps peel. And they found that probably with the diamond scratcher, probably you will have these Donfel effects will be more. And you can see here an example of a Donfel seen at the 1 month post-evaluation. And here you can see a case of Donfel which is occurring corresponding to the ILM peeling. So, and what is its importance is that whenever as a surgeon, when you are doing different techniques of macular hole, which could be a flower petal or cabbage peel or onion peel, variety of techniques, it will also help you to evaluate your own surgical technique. So recently I started doing this flower petal technique and I was trying to see how is the NFAS OCT, is it showing any Donfel effect? Some of these initial ones will disappear, but it will help you to evaluate your surgical technique as well. And here is another example of NFAS OCT showing an OCT section of a high myopic with a foveal chassis, which is seen only only on the nasal side. So, for example, in this case, if there is a progression is there and probably an ILM peeling, how much extent you can do, also probably you will be able to get a clue by using the NFAS OCT. And here is an example of epiretinal membrane. One can see all the tentacles and everything surface, which you can see very well on NFAS OCT. So you'll be able to know the structural and extent and the depth of the pathology. And here we don't really anymore require a FFA late phase to know the flower petal appearance of CME pattern seen on NFAS OCT in the macular edema. So NFAS OCT non-invasively, one can detect these changes. And Jeng et al., they have found that in venous occlusions, they found on NFAS OCT seeing a macrophage-like cells, which are seen as hyperreflective deposits. They are more commonly observed in acute phase of venous occlusion. So here I was just seeing this case in the clinic last week, and I observed that these actually in an old occlusion with a degenerative cyst and all, these hyperreflective deposits will be not seen as much as what you see in acute occlusion. So one will be able to know the acute versus chronic nature as well as being based on the NFAS OCT. And one can actually also map the PAM lesions very accurately on NFAS with a characteristic opacities as well as the periveneal deposition And one can actually exactly know the extent of the involvement of this spam along with the cilioretinal artery occlusion in this article by Raz et al. So one can see very clearly quantitatively map. So it will give you both quantitative value as well as the qualitative value. And in case of AMD, it helps us to quantify the geographic atrophy. In case of CNVMs, we will know the extent of the progression and extent of the involvement. And also, this is a case of old pruned network, and one can see the extent of the progression and underlying damage, layer by layer, and photoreceptor integrity. And this is another case where you will be able to know beautifully is cases like central serous retinopathy. Here you can see that the NFAS OCT is showing you the PED and everything changes, and the hyperreflective dots can be seen in the choroidal phase also. So one will be able to know layer by layer whether it is an acute type, simple type of CSR or a complex of type CSR using this imaging modality. This is again another case of complex central CSR where you can see very clearly NFAS OCT showing the gravitational trough. So one will be able to know whether it is a simple CSR we are dealing or a complex. And this is again in a follow-up period. Also, say a complex CSR, when you use an NFAS OCT, you can see at the AIOS junction level the kind of changes that you're seeing. And also one can quantitatively and qualitatively see in the follow-up periods whether the changes, how things are happening. And another interesting area where one can use NFAS OCT is in retinal degenerations like Stargardt's. So here in this article by Sodi et al., they have clearly shown, they compared fundus autofluorescence with the NFAS. So this is an example where fundus autofluorescence was showing some amount of hyperreflective changes, whereas in NFAS OCT at the level of the photoreceptor layer, there was no change that was detected. So this is a patient which was not showing at the degeneration at the level of photoreceptor. Similarly, a case of advanced atrophy where you can see the changes in the very clearly on the NFAS. And they also compared the both photoreceptor slab as well as sub-RP slab and photoreceptor slab, and they clearly concluded that the Stargardt's disease, the photoreceptor layer degeneration, those changes are much more common compared to compared to the RP layer. Telling that probably the disease starts at the photoreceptor degeneration going on to RP atrophy. So it will also give us insights into the pathogenesis. This is again a cases of hydroxychloroquine retinopathy where Hedge et al. They've clearly shown that the NFAS OCT at the baseline did not show any much changes, but at 2 years follow-up, this patient was showing due to chloroquine toxicity. In FAF, we could not clearly see the actual extent of the damage, but in NFAS OCT, one can see a clear circumferential area of showing the photoreceptor disintegration and showing the early toxicity. To summarize, NFAS OCT is a useful investigation. It adds life to your optical biopsy shown by the OCT. It is acquired during conventional OCT scan on the same machine. View is similar to fundus photographs, so easier to understand the disease and also interpret the findings to assess the disease prognosis better than the conventional longitudinal OCT scan. So, and disease-specific correlation, that is structural changes on NFAS OCT with the functional changes like FAF and clinical changes, there will be a definitely potential to reduce the need for additional invasive investigations. And definitely future is to look for NFAS OCT findings based guidelines to map disease progression and prognosticate. Thank you for the opportunity.
Dr. Srini, wonderful talk, Dr. Padmaja. It was so good. Could we have Dr. Srinivas taking the first question and then Jatinder?
Padmaja madam, wonderful talk as always. So would you prefer always using an ANFAS with the FA or with the IR? Or is it by default an IR and in select cases you order for FA or you order both IR as well as FA on the ANFAS?
You are mentioning autofluorescence, right?
Yeah, autofluorescence.
Yeah.
Fundus autofluorescence.
I think it's good to correlate with autofluorescence in diseases like retinal degenerations and dystrophies. But otherwise, in a regular like vascular disease and all, IR should be enough. But what I feel is more just comparison of your OCT itself with NFAS value. I think along with the fundus photograph and the clinical features in mind, it really adds a dimension to your thought process.
Jatinder, sir.
Jatinder.
Dr.
And
Padmaja,
very warm welcome, Satyajit. Unmute yourself.
Thank you, ma'am. Thank you, ma'am. Good to see you back from Africa.
Yes, Dr. Jatinder.
Dr. Padmaja, I have one query. I mean, what do you think are the limitations if it is so good as you have mentioned in your slides, and they were excellent pictures that you have actually described and very well demonstrated. But what do you think are the limitations? Why is it this not generally acceptable? Is it just mind block, or people are not explored this as an option? Or do you think there are certain limitations that would actually be of concern?
I think limitations will go on for as with the Octa learning curve, and then taking correct segmentation. Probably that is the most important layer, and probably NFAS OCT will definitely, whenever we order these investigations, we should definitely look at what layer the image is going, and then also the artifacts that comes with Octa. One should be able to be very careful. And why it has not really gained the interest is probably, I think, awareness and mind block. Otherwise, I think it adds beautiful value. In fact, Ritesh recently joined us, and we are going to change all our image protocols into NFAS ACTA to see in the report, because once it comes as a report and we start reading, and we'll be interpreting much more.
Dr. Aniruddha, you wanted to tell something?
Can I make one point? I think NFAS imaging, especially if you're operating epiretinal membranes, it becomes really important, because you can use your NFAS imaging and scan your deep retinal layers and see the level of wrinkling of the outer retina. And you can actually prognosticate these patients very well. Sometimes if you have photoreceptor wrinkling on the NFAS imaging, you know that these patients may not visually benefit so much. Whereas if the ERM is limited only to the superficial layers, those patients can have a better outcome. So I think NFAS is really catching up.
And I think NFAS OCT also should be part of any surgeon who does these macular surgeries, even as a post-op follow-up of your own technique, to understand how much the tissue damage is happening.
Thank you very much, Dr. Padmaja.